Bismillahirrahmanirrahim. Quote of the day, and say, do as we will, for Allah will see your deeds, and so will this messenger and the believers. Today, the topic of presentation is vertical program, two malaria control program, hepatitis control program, Sehat Sahulat Program, and lady health worker program. I am Dr. Rabbia Iqbal PGR Community Medicine, and I am presenting under the supervision of Professor Dr. Saira Afzal, Dean, Institute of Public Health, Lahore. Learning objectives of today's presentation is introduction to vertical program, malaria control program in Pakistan, national hepatitis control program, Sehat Sahulat program, lady health worker program, recent advances and MCQs at the end. Learning outcome at the end of this presentation, participant will be able to understand the vertical program, malaria control program in Pakistan, national hepatitis control program, Sehat Sahulat program, and lady health worker program. Introduction to the vertical program, defined as a disease specific and problem specific health program that operates through a separate administrative structure, dedicated funding, specialized staff, and independent monitoring system, and with the aim of achieving rapid and measurable outcomes. Background of the vertical program is emerged after the World War II, strengthened during global eradication campaign, for example, malaria and smallpox, popular in lower and middle income countries, high burden of communicable diseases, donor-driven funding, need for quick measurable result. In Pakistan, vertical program expanded significantly from 1980s onward. Why vertical programs were introduced? They were introduced when a disease became a major public health threat. There was a high mortality, morbidity. International agencies provide disease-specific funding. Rapid target-based control was required. Routine health system become weak. Characteristic of vertical program focus on a single disease or issue, separate management structure, independent budget and donor funding, specific objectives and time-bound targets, dedicated monitoring and reporting system, often operate parallel to the general health services. So we will discuss malaria control program, hepatitis control program, Sehat Sahulat program, and lady health worker programs. First is malaria control program. Vision of malaria control program is Pakistan free from malaria by 2035. Mission is to achieve malaria elimination by ensuring equitable and universal access to effective curative and preventive services to everyone at the risk of malaria in close coordination with efforts of all communities, national, international, non-government organization, private sector stakeholders, United Nations agencies, and financial partners. So the goal of malaria control program are ultimate interrupt transmission of and eliminate indigenous malaria throughout the entire country by 2035. Maintain malaria-free status in areas where malaria transmission has been interrupted and prevent re-establishment of local transmission. So the general objectives are reducing the incidence of malaria to less than one case per thousand population at risk in all provinces and federal territories by 2030, interrupting transmission of eliminating indigenous Plasmodium falciparum malaria throughout the entire country by 2030, interrupting transmission of and eliminating indigenous malaria in the phased manner progressed across the country by 2035, preventing the re-establishment of local malaria transmission due to importation in all the areas where it has been eliminated before and beyond 2035. So the components of this program is early diagnosis and prompt treatment, rapid diagnostic test at the peripheral facility, microscopic confirmation at the higher level, free provision of antimalarial drug, artemisinin-based combination therapy for Plasmodium falciparum, radical treatment for Plasmodium vivax, and this reduce the complication and transmission. So the second is vector control, long-lasting insecticidal net. It is distributed to the high risk and flood affected areas. Indoor residual spray, target spray is epidemic prone districts. Environmental management, removal of stagnant water and improved drainage system, and larval control measure, which chemical and biological methods where applicable. Surveillance system, passive surveillance, active case detection, high risk areas, case based reporting, monthly district level data compilation, early warning system for outbreak. Number D is epidemic preparedness and response. Rapid response team stockpiling of medicine, emergency vector control measure, special response during the flood and displacement crisis. Capacity building and community awareness, training of healthcare provider, community health education campaign, involvement of lady health workers. This is the figure showing the insecticide treated net distributed from 2009 to 2022, which was 3,55,672. So the stratification based on district classification by DOMC, all districts were subdivided and classified into three stria based on API, which is annual parasite incidence. Striatum 1 is API greater than 5, which is the high risk area. Striatum 2 is API in between 1 to 5, which is moderate risk areas, and striatum 3 is API, which is less than 1, which is low transmission areas. So this is the figure annual parasite incidence of the country was overall to 11.3. The highest ABI was reported at by Balochistan, which was 70.25, followed by Sindh, which is 25.10, and merged areas and Khyber Pakhtunkhwa. So the next is annual blood examination rate, which the overall annual blood examination rate for a country was 6.3, and in Balochistan 26.0 reported the highest annual blood examination rate, followed by the merged areas 11.8. So the test positivity rate, the test positivity rate was 17.4 overall, and Sindh reported the highest test positivity rate, which was 27.4, followed by Balochistan 27, and merged areas of KPK, which is 11.7. So this is the converse cases with year-wise comparison of all the Pakistan data for the major indicators. World Malaria Day is celebrated on April 25. Every 2 minutes, a child died of malaria, a preventable and treatable disease, is still claiming lives. So the, so the achievement of malaria control program are increased awareness. Community awareness about malaria prevention has been increased. Improved accessibility at the PHC level, better preparedness during the flood emergencies, increased availability, rapid diagnostic tests and artemisinin-based combination therapy are more available, strengthened surveillance, surveillance and outbreak detection capabilities has been enhanced, reduced mortality. Malaria mortality has been decreased in some areas, high burden districts. So the limitation of malaria control program is insecticide resistance, funding sustainability, weak surveillance, limit early detection, drug resistance, hinder treatment option, cross-border transmission, spread disease across the border, climate change, increase and decrease prevalence, limited access to care, and population displacement. So the next is hepatitis control program. The vision of hepatitis control program is hepatitis free Punjab is zero death caused by the complication of hepatitis. Goal is reduce mortality, morbidity due to hepatitis B, C by focus on all the areas with hepatitis alert 2018. Key strategies: robust surveillance in all health facilities, introduction of auto-disabled syringes, registration of barbers and beauty salons, mandatory screening of blood before transfusion, implementation of healthcare waste management in all health facilities, mandatory tests before dialysis, syringes and organ transplant, compulsory hepatitis B vaccine of newborn within 24 hours. So the guideline of the hepatitis control program guidelines are comprehensive national hepatitis strategy planning for HCV microelimination, simple and standardized algorithm for case management, integration of hepatitis test, care and treatment services, strategies to strengthen linkage from testing to care and prevention, decentralized services, task sharing, community engagement, and peer support to address the stigma and reach vulnerable and disadvantaged groups, efficient procurement, supply chain management of the medicine and diagnostics, data system to monitor quality of individual care and coverage. coverage of care. So the objective of hepatitis control program is in institutionalization of prevention control and secondary prevention control at secondary and tertiary healthcare facilities, improve assessed and updated service delivery package for hepatitis B and C, screening, diagnostic, treatment, and surveillance, integrated service surveillance, legislative framework for infection control, information, education, communication, awareness, and training of our stakeholders. So this is a diagram showing the prevalence of hepatitis B. Hepatitis A is 10%, 24%. Hepatitis B is 24%. Hepatitis C is 58%. Hepatitis D is 4%, and hepatitis is 12%. So there are two type of programs, which Punjab Hepatitis Control Program and PM Hepatitis Elimination Program. This is a comparison between these two. Punjab Hepatitis Control Program launched in 2005 and reconstructed around 2018, whereas PM Hepatitis Elimination Program is relaunched in 2024. Punjab Hepatitis Control Program is on the provisional level in Punjab only, whereas PM Hepatitis Elimination Program both federal and provisional level. In PM Punjab Hepatitis Control Program is pre-18 amendment provisional initiative. PM Hepatitis Elimination Program is post-18 amendment with federal coordination. So the vision of Punjab program is hepatitis-free Punjab and zero death due to the complication of hepatitis. PM Elimination Program eliminate B and C major public health threats by 2030. Goal is to reduce mortality and morbidity for HBV and HCV at the provisional level, whereas PM elimination program goal is mass screening, treatment, vaccination to achieve elimination. Scope is only Punjab program is only in Punjab, whereas PM elimination program is national wide, all provinces and regions. So the screening target in Punjab program is provisional strategy, no formal numeric target. And PM elimination program screen 50% of the population age greater than 12% by 2025 and 138 million by 2030. Treatment is to improve assess provisionally, whereas PM elimination program treat 9.8 million HCV patients by 2030. Elimination goal is control and reduce burden, whereas in PM elimination program is reduce new infection by 30% and mortality by 2030. So the vaccination emphasize HBV vaccination at birth and reinforce EPI. PM elimination program expanded HBV vaccine and strategy. So the achievement of these are strategy and drafted, reviewed hepatitis control cell in DHQ and THQ. Almost 281 cells are established. Micro elimination program. The program are focused eliminating hepatitis at the local level. Pre-screening and testing. Pre-screening and PCR testing are provided to the public. Free medicine distributed to the patients. Prisoner screening programs are also available. Division level meeting to discuss the program progress. So this is a stat. Total registered cases are 219,179 and screened hepatitis B and C is 161,858. These are the vaccinated against both HB vaccine, and the free medicine given to the patient 4,15,088. Limitation of hepatitis control program are low screening coverage, large undiagnosed population, especially in rural areas, weak linkage to the care, dropout between screening, PCR confirmation and treatment, funding and sustainability issue, diagnostic gap, limited molecular lab reagents, shortage, equipment maintenance issue, poor infection control, blood safety concern, inconsistent screening in small and private blood banks, human resource constraints, shortage of trained specialists and lab staff, weak surveillance integration, and reinfection risk. So the Partnership for Positive Change in Pakistan, ROSH has collaborated with the Pakistan's federal and provisional government in support of National Hepatitis Elimination Strategy, Prime Minister Program for Elimination of Hepatitis 2024 to 2030. The partnership focus primarily on diagnostic strengthening, not drug supply. Pakistan current install base of ROSH high throughout molecular PCR system set as a strong foundation. Installation of Cobas 68,000 slash 88,000 system in Pakistan, in North 2 system, Central 4 system, and South 7 systems. So the National Hepatitis Day on 28th July. Next is Sehat Sahulat Program. Introduction. A Sehat Sahulat Program is a social health insurance initiative in Pakistan designed to provide cashless health services to eligible families, reduce out-of-pocket medical expenditure. It works by the issuing health insurance card, commonly called as Sehat card or Sehat Insaf card, to the beneficiaries that allow them to receive treatment and in pallet hospital without paying at point of care. Launched in 2025 in Khyber Pakhtunkhwa and expanded to the other provinces. The program is implemented in the partnership with the federal government, provisional and territorial government, and the state life insurance corporation with manage reimbursement to the hospitals. So the objective of Sehat Sahulat program are reduce financial barrier to essential health care, provide universal and near universal coverage for eligible population, increase access to the secondary and tertiary services, promote health equity for vulnerable and low income families across Pakistan. So, who is eligible? Eligibility depend upon the province or region. In Khyber Pakhtunkhwa and some region like Gilgit-Baltistan, Azad Kashmir, all the residents with a valid CNIC are covered under the SSP scheme. In other areas like Punjab, Balochistan, Islamabad, Capital Territory, eligibility is often based on socio-economic criteria such as identified through National Poverty Database or being beneficiary of social support program. Individual can check the eligibility by sending SMS to CNIC to designated number, for example, 8500 for or to the official portal helpline. This is the official portal helpline link. So the services covered is cashless inpatient hospitalized care through the impaneled hospital, both private and government, including major surgeries, cardiac, orthopedic and general surgery, emergency admission and trauma care, ICU and critical care, normal and C-section deliveries, pre and postnatal care, chronic disease like diabetic complication, kidney diseases, dialysis and transplant support. Limitation of the Sehat Sahulat program is limited OPD coverage, mostly cover inpatient care, OPD medicine, diagnostic, and often excluded financial sustainability issue, high government cost, risk of delay, payment and budget strain, priority focus, emphasis on secondary, tertiary care, weak integration with primary health care, moral hazards, risk of unnecessary admission and overbilling in private hospital, assess inequity. Rural areas have fewer impaneled hospital, provisional variation in coverage, weak monitoring and regulation, and poor chronic disease continuity. No structured long-term outpatient management for NCDs. So the next is Lady Health Worker Program. Introduction. The Lady Health Worker Program is the one of the Pakistan largest community-based primary health care initiative launched in 1994 to improve maternal, newborn, and child health and expand access to the essential health services at the household level. It operates under the Ministry of National Health Services and the Provisional Health Department after the devolution. So the objectives are improve maternal and child health indicator, increase immunization coverage, promote family planning and birth spacing, provide basic curative care at community level, strengthen linkage between community and health facilities, support disease control program, for example, TB, malaria, polio, etc. So the coverage and structure over 1 lakh LHW deployed nationwide. Each LHW cover approximately 1,000 population, 150 to 2,200 households, work for her own home house within the community, supervised by the lady health supervisor. This make it one of the largest community health worker program globally. So the key responsibilities are maternal and child health, include antenatal and postnatal visit, counseling on the safe delivery, identification and referral of high-risk pregnancy, newborn care counseling, immunization support, include EPI session and sporting vaccination campaign like polio and measles, family planning, counseling on contraceptive method, disease control, TB door sport, malaria detection and referral, participation in polio campaign, health education for hepatitis and dengue, and basic curative care. So this is a diagram showing the input given by the government, which is policy and institutional framework of the LHW, training, HR management, monitoring and supervision, logistic management, budget and release decision. These resources are available to the LHWs, knowledge, client engagement, motivation, empowerment. The resource available to the client is availability to learn, trust, and empowerment, which the outcome from improved RMNC and improved women health. This is a figure showing difference coverage of key MNCH intervention by the LHW visits within the LHW covered areas. The orange shows the areas where LHW is not visited. Light blue show partially functional, and the dark blue shows the areas where the LHP and antenatal and postnatal visits. It clearly show there is a difference where the visit of LHWs for antenatal and postnatal. And this is the vaccine, measles vaccine, BCG vaccine, and full immunization program. So the limitation of irregular salary and job insecurities, heavy workload, multiple vertical programs, limited supply and medicine, security concern in some region, need for refresher trainees and digital integration. Next is the recent advances. This is an article published in 2025. Pakistan has the world's largest population living in hepatitis C, HCV, with the over 10 million active infection is for the Prime Minister Hepatitis C Elimination Program was launched in 2024, aimed to screen 165 million individuals over age 12 and eliminate HCV by 2030. The program used WHO pre-qualified diagnostic, locally manufactured antiviral and national electronic medical record system. So decentralization and community-based strategy include door-to-door screening, tasks into primary healthcare having been implemented. A successful pilot in Gilgit-Baltistan demonstrate feasibility informing national-wide scale-up. The program is fully domestically financed and often replicable model for other high-burden countries. So another article, systematic review malaria control, vector control strategy in Pakistan, published in 2025. So the background is malaria remains significant public health concern in Pakistan due to the subtropical climate and diverse array of vector contribution, periodic outbreak and challenges in disease. Recent outbreak, particularly in 2022. So the result of this, a total 46 article reporting surveillance finding a vector control method in Pakistan were found based on WHO recommendation. The reporting strategy include insecticide treating net 29.79, indoor residual spray 29.79, spatule spraying 12.79, and airborne repellent 4.26. So the larva source management and household modification is 4.26. In contrast, Khyber Pakhtunkhwa, which is employ ITNs 55 as the primary vector control method. Punjab was found to be use IRS as the main method of vector control, 50%. So the next is MCQs. MCQ number 1, a district in Sindh showed fluctuating malaria incident with seasonal peak, passive case detection report underestimate actual burden, which strategy would most appropriately improve epidemiological accuracy. A, expanding tertiary care admission capacities. B, introducing active case detection in high-risk swimming council. C, increase anti-malaria stock at district hospital. D, mandating hospitalization of all confirmed cases. E, restricted diagnostic testing to microscopy only.
B.
Yes, B is the right option. MCQ number 2, a district enters pre-elimination phase after sustained decline in incidence. Which strategic adjustment is most appropriate? A, focus on focal case investigation. B, expanding general mass spraying. C, prioritizing hospital-based treatments. D, limiting diagnostic information. E, reducing entomological monitoring.
A.
A.
Yes, A is the right option. MCQ number 3, high HCV screening rate are reported, yet treatment initiative remain low. Which system gap is most likely? A, inadequate linkage to the confirmatory test. B, excessive antiviral procurement. C, low community participation. D, reduced vaccinating coverage. E, limited tertiary care bed.
A.
Yes, A is the right
A.
option. Yes, A is the right option. LHW's report duplication of reporting across the vertical program, which reform would improve the operational efficiency. A, reduce catchment population size. B, integrated report through the digital platform. C, limit limiting services to immunization only. D, shifting work to the hospital setting. E, removing supervisory structure.
B.
B.
Yes, B is the right option. MCQ number 5, urban resident utilize SHP service more than rural resident despite similar eligibility. Which determinant most plausibly explain this? A greater impalement of the private hospital. B, lower disease prevalence in rural areas. C, higher insurance ceiling in cities. D, reduce awareness in village. E, increase preventive services.
C.
No, A is the right option.
E.
A is the right option, greater impairment of the private hospital. MCQ number 6, increased contraceptive uptake is observed in LHW covered communities. Which factor most directly contributes to this change? A household level counseling. B, specialist availability. C, surgical sterilization camp. D, expansion of tertiary hospital. E, increase in patient subsides.
A.
A.
Yes, A is the right option. MCQ number 7, following the flood, mosquito density increased significantly. Which intervention would most directly interrupt transmission? A, expanding dialysis services. B, increase empirical treatment. C, reconstrict outpatient services. D, centralized spotty diagnosis. E, indoor residual spray.
E.
D.
No, E is the right option, indoor residual spraying. MCQ number 8, a district plans microelimination of HCV among dialysis patients. Which intervention is most critical? Periodic ultrasonic screening. B, routine antiviral prophylaxis. C, strict infection control protocol. D, expanding liver transplant unit. E, community awareness campaign.
C.
Yes, C is the right option. MCQ number 9, which measure best reflect progress toward malaria elimination? A, increased empirical therapy. B, declining annual parasite incidents. B, C, higher hospital admission. D, expanded ICU services. E, reduce outpatient visits.
B.
B. B.
Yes, B is the right option. MCQ number 10, a health system introduced in a malaria eradication initiative with separate funding, management and reporting channel. The model best represent: A, integrated service delivery. B, horizontal health reform. C, vertical program design. D, decentralized governance. E, community-led intervention.
C.
C.
Vertical
C.
program.
Yes, C is the right option. So this is the answer key. This is the reference from where I took the data. This is the channel where this presentation will be uploaded. Thank you.